Henoch-Schonlein Purpura. The new terminology is immunoglobulin A vasculitis. Formerly it was known as Henoch-Schonlein Purpura or HSP. It is a small vessel vasculitis and ANCA negative. As I told, it is also known as immunoglobulin A vasculitis. It is one of the commonest vasculitis in children, especially in the age between 3 to 15. ACR criteria for immunoglobulin A or IgAV vasculitis is palpable purpura. That is the classical presentation. Age usually less than 20 years. Acute abdominal pain. Biopsy showing granulocyte in the wall of small arterioles or vein. So the ACR, American College Rheumatology criteria for IgAV can be remembered as a GPA 20. G for granulocytes in the wall of small arterioles and vein when we biopsy. P for palpable purpura. A for acute abdominal pain. And 20 is usually 20, less than 20 years of age. Pathogenesis. It is an immune-mediated vasculitis associated with IgA deposition. So there's going to be IgA deposition with complement deposition and neutrophil recruitment. But IgA deposition is the classical association. In the clinical manifestation, there is a tetrad of 4 things, which is palpable purpura without thrombocytopenia and coagulopathy. This is the classic diagnostic criteria, and as you can see in this picture as well, so you can actually palpate this purpura. It could be on the extensor surfaces of the limbs or on the buttock or on the back. The others are patient complain of some arthritis and arthralgias, acute abdominal pain, and kidney disease. How we gonna find out patient might have a protein to creatinine ratio of more than 0.2 or hematuria or hypertension, or it could be like microscopic hematuria with or without proteinuria or red cell cast. No diagnostic test, but you can do a biopsy, and in biopsy, basically skin biopsy, as it's more safer, more practical. And in the renal biopsy, you're going to find IgA deposition, which could not be differentiated between the Burgess disease or IgA vasculitis. So better to go for a skin biopsy of a palpable purpura site. In histology, you're going to find a leucoclastic vasculitis with IgA deposition. The differentials are because it has a purpura, so it should be differentiated between ITP and HUS. So in the BCQ scenarios, the other options could be ITP and HUS. The most characteristic finding associated with HSP, Henoch-Schonlein Purpura, is that the coagulopathy will be normal. There is no coagulopathy and there is no thrombocytopenia. Histological findings in kidney is the presence of galactose deficient IgA1. So there would be a GD-IgA1 would be present. In the in workup, you can find hematuria, maybe macroscopic red cell cast, proteinuria. Patient might be hypertensive. Prognosis is really good in children. It is a self-limiting disease, but in adults there are more complications, especially the renal involvement. Treatment is supportive. Analgesia. The role of methylpred in acute crycentric nephritis is there, but as a self-limiting disease and relapse occur in 1/3 of the patient. Complication, most important thing, patient might present in emergency with intestinal perforation, as there is an abdominal pain there, so we need to be thinking about this possibility as well. Renal failure and hemorrhage. Treatment algorithm for the management of IgAV patients according to the organ involvement. If there is a skin or joint involvement, we can start with a symptomatic treatment like analgesics and resting usually avoid ansets if renal or digestive involvement is there. Colchicine 1 milligrams per day in case of a failure. GIT tract involvement, benign form, symptomatic treatment, severe form, surgical evaluation of prednisolone or methylpred plus immunosuppressive plus minus surgery could be there. Renal involvement very important if this is the mild form like a mild hematuria, proteinuria is less than 0.5 grams per day, normal EGFR there, then you can keep patient at observation and evaluate at 3 and 6 months. If it's a moderate form, like hematuria, proteinuria is more than 0.5 grams per day, but EGFR is normal, can start patient on ACE inhibitors or can review the patient in 3-6 months time. Severe form, that is acute or rapidly progressive renal failure and concentric lesions there, can start patient on prednisone 1 milligrams per kg per day or methylprednisolone pulse therapy, that is we give 1000 milligrams of methylprednisolone for 3 days plus minus cyclophosphamide immunosuppressive therapy can be given. If it failed, then alternative immunosuppressive can be considered. So this is all about Henoch-Schonlein Purpura. We'll end this important topic with one BCQ. So the questions can come in exam like this. For example, they are asking what is the most probable diagnosis here. We have to diagnose according to the scenario. 17 years old boy was admitted with 2-day history of a lower abdominal pain, blood-stained diarrhea. 3 days later, he developed pain in his ankles. On examination, there was a purpuric rash affecting the arms and leg, periorbital edema, blood pressure of 150 by 95. Investigations, hemoglobin is low, white cell count is a bit high, platelets are normal, PT and APTT is normal, creatinine is raised, urinary analysis, proteinuria and RBCs are present. Young patient coming with abdominal pain, purpura, renal involvement as cleared by the creatinine with hematuria and RBCs red cell cast is most likely Henoch-Schonlein Purpura. Why it's not HUS? Because the coagulopathy is normal. Why it is not IgA nephritis? Because there is other involvement like a purpuric rash and acute abdominal pain is there, not only the renal involvement. And most likely it is HSP.